Can I start, ma'am, now?
Yes, sir. Please, sir.
Hello and welcome everyone. Myself, Dr. Sachin Patil, on behalf of Maharashtra IAP. We are today hosting a webinar on cardiopulmonary resuscitation. We all know that almost since 17th to 24th of July, the CPR week are celebrating all over the India, including Maharashtra also. Various activity was done throughout these days to get more and more people aware of basic life supports, especially CPR. Now we all know that the saving of anybody's life is the most rewarding one. Now for this session, I am moderating now, and various faculties from all over the Maharashtra, like Dr. Mandar sir, Minas sir, Dr. Sonali Sirbate ma'am, and Dr. Narendra Nanavadikar sir are there with us. I heartily welcome all. Now I request Hemant Kangulia sir, President of MahaAP, to have a opening remarks for this webinar.
Thank you, Dr. Sachin. Good evening and namaste to each and everyone, respected faculty, Dr. Meena Sheikh, Dr. Mandar Deshpande, Dr. Narendra Nanivadekar, Dr. Sonali Shirbate, who is also Women's Committee Co-Chairman, my Secretary General, Dr. Amol Pawar, moderator of the session, Dr. Sachin Patil, editor, Dr. Neha Singh, and all those who are attending, as well as the viewers on the MahaAP YouTube channel. Yes, 21st July is the CPR, National CPR Day, and cardiac pulmonary resuscitation is very important. Each one can save a life. That is a theme. And going on that, this is a very important topic to be discussed, and probably I feel it should reach each and every person across the country. And yes, heartiest congratulations to all the branches across the Maharashtra celebrating this day in a very big way, reaching to the school, colleges, as well as the institutions. So lots of work going in the Maharashtra state. But still, I feel that it should reach to the common person or lay person, to each and every place of this. And probably what we see and what we observe, that this is almost training is there, but that training, I think so, we should, as a this is a request from my side to the faculty, let us have these videos which should be in the vernacular language, and it should go across the things to make it vernacular, and each people should understand in their language, so it will work. Otherwise it remains mostly on the teaching for only those week. This should be 365 days a year, so as to so one can really save the life. With that note, I feel so we will be enriched ourselves with the latest guidelines, whatever is there in the CPR and we have wonderful faculty, and we will have a good learning session. Wish each one and everyone a happy learning. Thank you, Dr. Sachin.
Thank you, sir, for your opening remarks. Now, without wasting much time, we will proceed with the first session. First session is for basic idea regarding the CPR. This session will be done by Dr. Sonali Shirbate ma'am. She is a treasurer for Human Will Back in India 2020 and 22. She was a past president for IAP Amravati to 2018. She is now EB member of Maharashtra IAP. At the same time, she is also co-chair for Women's Committee MahaAP and trainers for IAP, various IAP modules, and BLS and NRP NTP. Now, I request Sonali Shirbate ma'am to proceed with the further session.
Hello. Are the slides visible?
Yes.
First of all, I would like to thank Dr. Gangolia sir and Dr. Amol sir for the opportunity given to me. And I'm really very fortunate that today I am co-faculty with especially Meenakshi sir, Nanivadekar sir, Mandar sir, Dr. Sachin sir, because from all of them I had learned, and I am here now. And I'm also thankful to Dr. Manish Jain sir and Dr. Manish Doshi sir. So as you all know, CPR week is celebrated from 17th July to 24th July. Now today we are taking the awareness session so that each and everyone should know how to do the CPR. Before going to the details of slide, giving some of the examples. you must have heard that passenger gone on first flight suffer cardiac arrest. But there was a doctor there present, and the cabin crew requested him, and the life was saved. So in the few sets of seconds, the life was saved. The second example is again here the CPR was done by a Williamsport doctor and over the flight, and the woman was saved. So the lack of CPR awareness is a big challenge in India. Among the India's population, less than 2% are aware about the CPR, and every minute 112 people are succumbing to the cardiac arrest. And as you all know, the recent breaking news like Siddharth Shukla and Puneet got cardiac arrest, but both of them did not receive timely CPR. So this is the significance of the CPR day, that each and every one of us should know the CPR, at least the primary procedure of cardiac compression. This CPR day is celebrated in the fond memory of Dr. Anand Shantinlia sir. He was the past national convener of IAP ALS BLS. So moving to our session now, what is CPR and BLS? CPR is cardiopulmonary resuscitation and BLS is basic life support. BLS is a sequence of steps to perform the CPR. This term was promoted by American Heart Association. Then who needs CPR? Any victim of sudden cardiac arrest needs CPR. So there are two different scenarios. CPR in SCA in adults means cardiac arrest. The reasons of cardiac arrest in adults are usually the rhythm abnormalities like ventricular fibrillation, pulseless ventricular tachycardia. Not every time the myocardial reason is there. And in children, especially the cardiac arrest is major cause is respiratory failure or shock. So always not there heart attack in the adults. Please remember this. Then a victim of cardiac arrest has a best chance of recovery if the person standing next to him immediately recognize the condition and does the CPR. 95% of them can be saved, and CPR has to be initiated immediately upon recognition within first 4 to 6 minutes. It saves the life. So this year the theme is each and everyone can save a life. Then how to recognize cardiac arrest? Because we should know when to do the CPR. A victim of a cardiac arrest, this is in case of adult, the slide in case of adult. There are 3 signs from which we can diagnose a cardiac arrest. Patient is unresponsive, patient stops breathing or is gasping, and patient does not have pulse. Means we have to see the 3 signs: responsiveness, pulse, and breathing. And in case of child, there is usually the same, but the child is labeled as in cardiac arrest when there is cessation of circulation or absence or ineffective mechanical cardiac activity. That is, the child is unresponsive and may be gasping or breathing, and he is in shock. The pulse may be feeble or may not be palpable. So these are the 3 signs, that responsiveness, pulse, and breathing. From that, we can diagnose the patient is in cardiac arrest, and we have to start the CPR. So let us know about the steps of CPR. First, we will know about the adult CPR. Then, first of all, as you know, we had seen various scenes that n number of people are getting, especially like floods or in drowning, and we are seeing now. But when to do the CPR? Because scene safety is also important. Because if we are saving that life, our safety is also important. So assess whether the scene is safe to help the victim. Look for any evidence of drugs, poisoning, or other things. Because if the patient is in poisoning, then we have to look for it, because we can be also victim. So assess a victim for a response, but the scene should be safety. Like these are the few slides we had taken. These shows the verify the scene safety. Your own safety should be a priority, because then and only you can save the life. Now moving to the check for the response. How would you check? Firmly tap on the victim's shoulder or ask him question. Are you okay? Hello, hello. Are you okay? How are you? Do you need some help? From these questions, you you would come to know that the patient is responding or not. Then second thing, activate the emergency response system. Get an ED. What is AED? AED is the defibrillator. In the foreign countries, it we have to dial the number and the people blue coat team comes. But in our country, we have to dial 112 or 108 to get an ambulance with a AED to be available. Then why to activate the emergency? We should start the CPR. Yes, we are starting the CPR, but we have to activate the emergency response because after doing CPR for say first 5 minutes or 2 minutes, 3 minutes, we get exhausted, right? Then we need the help. And if we are alone, we have to do. If we are two, then it's okay that we will switching off. But till the help is arrived, till the aid is arrived, till the help is arrived, we have to continue the CPR. So the activating the emergency response system is very much important. Then checking of the breathing and pulse check. Look for the normal breathing and carotid pulse simultaneously. In adult, it is very simple. You can do it now also. Put just fingers on your throat and move it laterally. You will palpate the carotid pulsations. And from that, you will come to know whether there is patient is having pulse or not. It should not take more than 10 seconds to diagnose it. Then determine the next action. See, this slide is very important. If patient is breathing and is normal pulse, then monitor the victim till the help arrives. He can be taken to the hospital. Keep in recovery position. I will tell in next slide, we will see the recovery position. If the patient is not breathing, but the pulse is okay, pulse is present, then provide rescue breathing. Then here I would like to tell you in the rescue breathing, if you are carrying a pocket mask, many of the doctors are carrying a mask with them usually. Then with the pocket mask, you can give the rescue breathing. But if the pocket mask is not available on time, you have to give the mouth-to-mouth rescue breathing. If no breathing and no pulse, then you have to start high quality CPR. Then what is high quality CPR? We are going to see now. So this is the recovery position. The hand is kept under the chin to keep the mouth open and patient has to be kept in lateral position. This is the recovery position till the help arrives. But when you have to do it, when patient is breathing, patient is responding and there is pulse is also present. Then high quality CPR, when we have to do, then there is no pulse, patient is not responsive, there is no breathing. Position yourself to the victim side. Place the victim on the flat firm surface because CPR you have to do, you can't give it anywhere like on the table and all. You have to take the patient on the flat surface like on the ground. Place the heel of your dominant hand of your lower half of sternum. You can use the heel of your hand and place the other hand on the face so that make a firm grasp of the fingers of the second hand. And straighten your arm, that is perpendicular. Your arm should be perpendicular and directly over the your shoulder, directly over your hands. This is the proper position of high quality CPR. Because if you are not going in this position, you are sitting like anything, then you will going to be exhausted in just 1 minute only. So this position is important. And second thing is, if you are in this position, then only you can give the high quality CPR. So the cycles of the compression and breaths, the universal ratio is 30:2. 30 is for the compression, 2 is for the rescue breaths, either by mask or by the mouth-to-mouth rescue breaths. So you have to push hard up to the 5 to 6 centimeter. I am going to show you video after this talk. Then you have to push fast so that the rate should be 100 to 120 per minute and deliver compression in a smooth fashion and allow complete chest recoil at each compression. So you have to remember the 30:2 sequence and you have to push hard, push fast and allow the complete chest recoil. Then you have to minimize the interruption, count while delivering compression like 1, 2, 3, 4, 5, so that you will come to know the 30 compressions you are giving. Then open airway to deliver the 2 breaths. You have to give 2 breaths after the 30 compressions. And AD till that AD arrives, you have to give the defibrillator shock also. The machine usually show whether the rhythm is shockable, then only the machine delivers the shock. If it is not shockable, the machine doesn't deliver. But remember, when the machine delivers the shock, you have to stay out of the patient for some distance while delivering the shock. This is the automated external defibrillator machine. It analyzes the shock and it gives the shock. And along with we have to continue after that also CPR. So this is the position of opening airway, head tilt and chin lift maneuver. Usually you must be knowing that anesthetists are doing it regularly while giving the anesthesia. But here we have to do this position to give the rescue breaths. Head tilt and chin lift opens the airway in a straight way, and it has become easy to deliver the breath up to the lungs. These are the position which should be avoided. The third one is the most common position of bending, which is totally wrong because it is too exhausting and the compressions are not delivered properly. Now let's move on to the child CPR. The details of child and infant CPR will be told by our co-faculties also, but here are the primary basic things I am telling. In the children, there is some difference in the children and adult. Please remember this. I am showing you some difference there is. From age of 1 year to puberty, is considered as children. The puberty is the chest or underarm hairs on male and breast development of breast in females. At the time of scene, we have to analyze it whether the victim is children or victim is adult. Because in adult, 30:2 sequence we have to follow, but in children there are some difference. So the definition of puberty is given here. So, but there is some difference. If the arrest you witness and you are, if you witness the sudden arrest of a child and you are there, then you have to leave the child and you have to activate emergency response first, get an AD, and then you have to do the CPR. But if you had not witnessed, then first do the CPR. पहले CPR कीजिए और उसके बाद में आप help के लिए emergency system activate कीजिए. There are some of the difference. Why this is the difference? Because the shock is the main cause, especially of cardiac arrest in children. So we have to follow this rule. Then pulse check in carotids, I have told you, or femorals is also easy in children to palpable, and so that we can know. And in infants, we palpate the brachial pulse. There are differences in adult and child. The single rescuer, you have to give the same breath like 30:2 like adult. But if you are two rescuers, then remember 15:2 sequence you have to follow. 15 compression, 2 breaths. Compression technique either by one hand or heel of the hand, or if the child is obese or big, then the same sequence as the adult. And if there is infant, we will come to know from the another our esteemed faculties. The compression depth should be 5 centimeter. So these are the some of the differences, but what we have to remember is single rescuer 30:2, two rescuer 15:2. While the adult there is 30:2 only. Infant CPR. Infant below the age of 12 months is considered as we define it as infant. So when we have to activate the emergency response system, as for the child it is same. Then we have to palpate the brachial pulse here. I will show you the diagram to palpate the brachial pulse, and the techniques we will coming to know in the further talks also. But here I am showing some slides of this. And the compression depth should be 1/3 of the epidiameter of chest. The ratio is the same as children, 30:2 if there are 2 rescuers and 15:2 if there are 2 rescuers. So this is the slide. Brachial artery pulse check. You have to keep your thumbs in the arms in the inside of the arm to know the brachial pulse. These are the compression techniques of infant: single rescuer, 2 finger technique, and if there are 2 rescuers, the another rescuer is standing on the head side with the to give the compression of the breathing, and the second one is giving the compressions. So 2 thumb technique is applied here. So, dear delegates, there is no greater joy than bringing back life into lives and smile on the faces. So, just a few seconds can save someone's life. So, hope I had given some basic and it is useful to you to know the details of CPR, and please apply it whenever it is possible for you. Thank you. Thank you very much. Showing you another adult CPR, just a 1-minute video I'm sharing here.
We will now learn the complete BLS sequence for one rescuer.
Coming through. Scene is safe. Hey, are you listening to me? He's not responding. There is no circumstantial evidence of drug abuse or poisoning. Somebody please activate the emergency response system and get an AED. He's not breathing. There's no pulse. Start CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Thank you all. These were the basic video to know about the compressions. Thank you.
Madam, one question.
Yes,
If you don't have device to put on the mouth, then what to do? We
Sir,
don't
we had to-
move. We don't move with that. So how do we do give the mouth breathing?
Sir,
In
we
the
had to
video,
give-
you have shown the device which was kept on the mouth and through which the mouth to mouth respiration was given. So if
Yes,
it
yes,
is
sir.
not there, we don't keep with us. So
Yes,
what to
sir.
do?
Sir, direct mouth-to-mouth breathing, you have to give with a normal breath. We have to blow in the, we have to pinch the nose of the victim, of the patient, and we have to give the mouth-to-mouth breathing to the patient. Two rescue breath we have to give, and not much of the deep, the person who is giving breath should not take the deep breath. It should be normal breath, and you have to blow in the mouth of patient.
So the response to this question is like this,
Yes.
especially with regard to COVID scenario.
Yes.
So there have been certain reservations giving the mouth-to-mouth breathing during COVID. However, life is precious than feelings. So considering, it is left to the individual rescuer to go ahead and do the, like, if you don't have you can have some, some tissue paper, something like that, some barrier, but it is not recommended. It is not studied. But what is said is definitely to be careful when you are having mouth-to-mouth breathing during the COVID period.
So because it was said sometime that the handkerchief can be or the tissue paper can be used, whether it is recommended or not.
Yeah,
Yes,
as
Dr.
far as,
Nani.
Dr. Nani will say, but as far as my knowledge goes, these things have not been studied. So these are only hearsay. So Nani is the right person to answer.
It's everyone's here. Yes. See, Dr. Minaj, what you have said is absolutely correct. During COVID, there was a big question mark. Am I going to get COVID? Now, after 2 years, I think all of us have got
Vaccine.
the COVID or we have got the vaccines. The worst thing which can happen is we'll get COVID. That will be just a test. We may test ourselves, we may not test. Important is, as Dr. Ganguly said, the life is precious and we should always give credence to that.
Yes.
So from that angle, although we have not made a statement from BLS group,
Yes.
one-to-one, if tomorrow the situation comes to me, I am not going to hesitate giving a mouth-to-mouth respiration. But at the same time, because I'll be trying to put a phone number on the chat box, which can be utilized by anyone. There's one person who is giving pocket masks, and all of us, I have already got 3 of them. I put them in all my vehicles because that is something which is going to be very helpful for all of us. No question about it.
So, and I stop with this, like what Sarah says, if you save one life, we save humanity.
Yes.
Yes.
Absolutely correct.
The question I raised, little bit reluctance comes to the mind, because therefore I asked that question to make the things very clear what to do.
No, this question is practically asked almost wherever we went this time in the last 7 days, and people have been asking those questions, which is very practical as well. And the answer to what Naren sir and we have expressed. Yeah.
Thank you.
Thank you, Sonali ma'am. Madam have explained in very simple ways regarding the basics of cardiopulmonary resuscitation, the techniques behind the CPR, and the different small little bit differences which are there in the infant, adult, and pediatric like child CPR. So now, no many questions. There is no questions right now. So we will go ahead with the second talk regarding the guideline changes in the 2020. The talk will be given by Dr. Narendra Nanavadikar sir. He is our beloved executive body member of 2021-22. He is a national convener for the IAP BLS group 2021-22. He is a consultant pediatrician from Kolhapur only and owner of Niramay Pediatric Nursing Home. Now, I request Narendra sir, please go ahead with the slides.
Thank you, Herman Bhai. Thank you, Amol, for giving me this opportunity to talk on the CPR day. Since last one entire week, this 1, 2, 3, 4, 5, 6, 7, up to 30 is 2 is all embedded in our mind whenever we get up. Even my younger daughter has learned it by heart because she comes with me for this mass awareness programs. So Dr. Sonali has already given us good guidelines. She has given us an idea about what BLS is and how we are going to deliver the CPR. Now I'll just go into a little bit of science and the guidelines changes in 2020. As I hope my slides are visible and my screen is visible.
Yes, sir. Yes.
Yes.
So we decided to celebrate this IAP CPR day on 21st of July 22. But as a national convener, I myself had put it across to Central IAP that one day is not going to be sufficient for us. So we'll have to have the activities all over the country, all over the week. So any activity which is done from 17 to 24 should be considered as IAP CPR activity. And the theme which we chose was each one can save a life. So with this, we'll start with our talk. As you can see, it is important that we learn how to do a CPR. Okay, because unless we are in a position to do CPR, we will not be able to save lives because it's good for me, I get to live. So this is just a lighter mode on this CPR. So where do we stand as far as the cardiac arrests are concerned? Now you know that these are the leading cause of mortality as well as morbidity in the all over the world. And the data, again, majority of the times we are dependent on the Western countries for the data. So in US, they say that there are 347,000 adults and more than 7,000 children, which is not a small number, with an out of hospital cardiac arrest each year. And if we try to extrapolate that in our country, you can imagine what will be the number. And in hospital cardiac arrest is estimated to be 9.7 per 1,000 adult cardiac arrest, which are almost 292,000 events annually, and 2.7 pediatric events per 1,000 hospitalization. To add to it, there are 1% of newborns which require intensive resuscitative measures to restore cardiopulmonary function. So the requirement is always there. Now, why it is important that resuscitation should be done? So most important is get early identification of any person, be it an adult, be it a child. Going into cardiac arrest can be helped by high quality CPR. And if you see the survival, both out of hospital cardiac arrest and in hospital cardiac arrest, there is definite increase in the survival, and there is overall survival to hospital discharge rate figure are better in in-house cardiac arrest as compared to the out of hospital cardiac arrest, for the simple reason that out of hospital cardiac arrest, there is no bystander who is ready to give CPR in the initial phase, and that is the most important time where the CPR needs to be administered. So why there are guideline changes? Because what we learned as an initial facilitator and what we are learning today, there is some change. Because medicine is an evolving science, resuscitation is also a part of the medicine. So it is going to evolve over a period of time. So the guidelines are changed by American Heart Association with ILCOR. So over a period of time, we also may be a part of that. So the whole idea is to improve the survival of an arrest patient and also to have a neurologically intact survival, because there is no point in resuscitating a child or an adult who is going to be having vegetative life, because that's not a good idea. So what we need to know is good resuscitation outcomes will depend on the guidelines will be based on sound resuscitation science, will be effective education of lay public and resuscitation providers, and implementation of a well-functioning chain of survival. Now this chain of survival, what we talk, is a very important aspect, and this has already been covered about high quality CPR. So these are pediatric chain of survival in hospital as well as out of hospital. Now if you see, in hospitals, this early identification, we have to activate the emergency response, high quality CPR, advanced resuscitation, and post cardiac arrest. So in hospital, these are important aspects, a good post cardiac arrest care as well as recovery, because recovery also is an important thing. And then out of hospital, see, prevention is important. Try to prevent the cardiac arrest by using various measures, but identified, you have to activate the emergency response, high quality CPR, advanced resuscitation, followed with post cardiac arrest care, and followed with recovery. So we are not going to go into the details of this because this has been oft repeated. What is important, few important things is check for responsiveness, shout for nearby help, activate the emergency response system via mobile device if appropriate, how we will see together later on, and provide rescue breathings, one breath every 2 to 3 seconds, about 20 to 30 breaths per minute. This has been identified especially for the pediatric basic life support, and assess pulse not more than 10 seconds. As far as the breath is concerned, all of us know in pediatric arrest is usually the respiratory cause, and breaths are important. And if there is a child who is breathing, so rescue breaths have to be given one breath every 2 to 3 seconds. Using mobile devices to summon rescuers. The new guideline, the use of mobile technology by emergency dispatch to alert the willing bystanders to nearby events that may require CPR or AD is reasonable. And reasoning is lay first responders will definitely improve the out of hospital cardiac arrest. Most communities, and this applies not only to India, because in India the awareness is less, but even in Western countries the awareness of the bystander CPR and AD use is less. So if they are utilized, then that will definitely make a difference. And there is a recent ILCOR systematic review which has found that notification of lay rescuer via smartphone app or a text message alert is associated with shorter bystander response time. It can give a higher bystander CPR rate. It can give a shorter time for defibrillation. And of course, all this will culminate into higher rates of survival to hospital discharge for people who experience the out of hospital cardiac arrest. The changes of assisted ventilation ratio, which we already talked, the infants and children with a pulse with absent or inadequate respiratory efforts, it is reasonable to give one breath every 2 to 3 seconds. Previously, if there is a palpable pulse rate or greater than or inadequate breathing, give rescue breaths of 12 to 20 minutes, one breath every 3 to 5 seconds until spontaneous breathing resumes. The reason was that it was shown that 20 to 30 breaths are giving a better outcome. The changes for assisted ventilation rate with during CPR with an advanced airway. If there is advanced airway which has been put by paramedics, then you can give 20 to 30 seconds depending on the age and clinical condition. Rate exceeding this may compromise hemodynamics and they will not be effective. Old guidelines where if the child or infant is intubated, ventilate at a rate of one breath every 6 seconds, that's 10 per minute, without interrupting chest compressions. Obviously, for all of us who know resuscitation, whenever there is an advanced airway which is put in, we can continue to do a simultaneous ventilation as well as compressions. The reasoning is no data about ideal ventilation rate during CPR without an advanced airway or children in respiratory arrest with or without advanced airway. For simplicity of training, respiratory arrest recommendation was standardized for both the situations. Now the next thing is the mobile phone. We already talked about the mobile phone, will not go into detail. The second thing is the epinephrine. Now whenever the paramedics are there, when we see that the patient does not need a shock, if suppose the patient is needing a shock and if the aid is available, shock always gets a priority. But if there is a need of epinephrine if the child has got asystole or PEA. Of course, this does not apply to the BLS. This stands for a CPR. So cardiopulmonary resuscitation, because this is an in-house where you have got equipments which are available, you have got medication which are available. So over there, epinephrine as soon as possible. There is a highlight of this particular document. Emphasis is on early epinephrine administration. For any setting, it is reasonable to administer the initial dose of epinephrine within 5 minutes from the start of compressions. The old recommendation was to administer epinephrine, but there was no stress on within 5 minutes. The early epinephrine versus late epinephrine, for every minute delay in administration of epinephrine, there was a significant decrease in the ROSC, this is return of spontaneous circulation, and it was definitely affecting the survival at 24 hours and even survival to discharge. And of course, survival with favorable neurological outcome. So if all these criteria of 24-hour survival, survival to discharge, survival with favorable neurological outcomes are better than epinephrine, better with an early epinephrine, then early epinephrine is definitely indicated. Of course, if you have got an IV or IO access, then you push epinephrine through that. If not, you can give it through the endotracheal tube. So this we have already talked about this, the advantage of using epinephrine within first 5 minutes. Then about the child with bradycardia. Then this is the CPR changes. You do an QRS evaluation. This is a child with tachycardia, pediatric tachycardia. Will not go into details of this. Cuffed endotracheal tubes. Whenever the child is intubated, previously our teaching was that you use an endotracheal tube which may not be cuffed. You use it for a slightly higher age group. But now updated guidelines say it is reasonable to choose cuffed endotracheal tube over uncuffed ET tube for intubating infants as well as children. Also, the formula is different from the routine one. When a cuffed ETT is used, attention should be paid to the ETT size, position, and cuff inflation pressure, which should be less than 20 to 25 centimeters of water. Previously, both cuffed and uncuffed endotracheal tubes are acceptable. In certain circumstances, a cuffed ETT may be preferable. The reasoning is that several studies and systematic reviews have shown the safety of even cuffed endotracheal tubes, and they have demonstrated decreased need of tube changes and reintubation. Cuffed tubes may decrease the risk of aspiration, and if it is careful technique is followed, then subglottic stenosis is rare with cuffed endotracheal tube which are used. The routine use of cricoid pressure. This is another important thing which has been changed. Updated 2020 guideline says routine use of cricoid pressure is not recommended during endotracheal tube. The old guideline was there was insufficient evidence to recommend routine application of cricoid pressure to prevent aspiration during endotracheal intubation in children. The reasoning was new studies have shown that routine use of cricoid pressure reduces intubation success rates and does not reduce the rate of regurgitation. And the writing group has reaffirmed the previous recommendations to discontinue cricoid pressure if it interferes with the ventilation or the speed or ease of intubation. And those who have been intubating regularly in the hospital can experience that there is no need of giving a cricoid pressure. This is yet another guideline which has been added, invasive blood pressure monitoring. Of course, this will be applicable only in an ICU setting. For patients with continuous invasive arterial blood pressure monitoring in place at the time of cardiac arrest, it is reasonable for providers to use diastolic blood pressure. Of course, now logically, you will understand that suppose there is a critically ill child who is admitted in an ICU and who has undergone cardiac arrest, then this will be applicable. Because if suppose there is a child who is arrested in an emergency department, there won't be any chance of putting an invasive arterial pressure monitoring for such a child. So this is only in a hospital, that too in an ICU situation where which will be applicable. But important is to diastolic pressure will be an important guideline to see the CPR quality. The old guidelines for the patients with invasive hemodynamic monitoring at the time of arrest, it may be reasonable to use blood pressure. And over here now it has been shown that diastolic blood pressure is definitely a good guideline, because it has been seen that the rates of survival with favorable neurological outcome were improved if the diastolic blood pressure was at least 25 millimeters of mercury in infants or at least 30 millimeters of mercury in children. Then detecting and treating seizure post ROSC. Again, this will be applicable in an ICU setting, and that too with ICU setting which have got an invasive, which have got a EEG monitoring which is possible. So the guideline says whenever resources are available, continuous EEG monitoring is recommended for detection of seizure following cardiac arrest with persistent encephalopathy, treat seizures following cardiac arrest and non-convulsive status epilepticus following cardiac arrest in consultation with experts. Because not every time the child is going to show you a seizure which is clinically visible. So a non-convulsive status also is important and we need to be treated effectively. The old guideline was the EEG should be done for diagnosis of seizure, should be promptly performed. The reasoning is both convulsive and non-convulsive status epilepticus treatment is beneficial. Then the components of the survival, whenever the patient is post-arrest care, there is emphasis on the targeted temperature management. The rest of the things will come, but I'm focusing on the targeted temperature management. Measure and continuously monitor the core temperature, prevent and treat fever immediately. If the patient is comatose, apply the targeted temperature management of keeping it between 32 to 34 degrees, followed by 36 to 37, or only TTM, that is 36 to 37.5 degrees centigrade. Prevent shivering and monitor blood pressure, treat hypotension during rewarming. This also continues. The prognosis will always consider multiple modalities with or any single predictive factor, and TTM also is going to be important as an assessment. Consider EEG, consider neuroimaging during first 7 days. And in post-arrest rehabilitation, it is recommended that pediatric cardiac arrest survivors be evaluated for rehabilitation services. It is reasonable to refer the pediatric cardiac arrest survivors for ongoing neurological evaluation for at least first year after the cardiac arrest. The reasoning is recovery from cardiac arrest continues long after initial hospitalization, and survivors may require ongoing integrated medical, rehabilitative, caregiver and community support in the months to years after their cardiac arrest. And the recent AHS scientific statement highlights the importance of supporting patients and families during this time to achieve the best possible long-term outcome, because we have already said that we would like a neurologically intact child as an outcome of our cardiac CPR. So these are long-term, short-term, medium-term, and these are the various goals. Let's not go into details of all this. Then a quick look at the septic shock fluid boluses. Enough here or to say that in a patient with septic shock, it is reasonable to administer 10 ml per kg or 20 ml per kg aliquots with frequent reassessment, because there are few studies which have already been done which show that excess fluids also can create problems, especially in a child with severe sepsis, malaria and dengue. The African trials which have already been done. The choice of vasopressor is epinephrine or norepinephrine as an initial vasoactive infusion, and in infants with fluid refractory septic shock, if epinephrine or norepinephrine are not available, only then dopamine should be considered, because 2 RCTs have shown that epinephrine is superior to dopamine as the initial vasopressor in pediatric septic shock, and norepinephrine also is appropriate. Corticosteroids for infants and children with septic shock unresponsive to fluid and requiring vasoactive support, it may be reasonable to use a stress dose of corticosteroid. Reasoning, while resuscitating with fluids, fluid overloads can increase the morbidity. Previous versions of guidelines did not provide recommendation about use of corticosteroids in septic shock. Recent clinical trials suggest a benefit for corticosteroids administration in some patients with refractory septic shock. Hemorrhagic shock, again, it is logical, and it is even logic tells us that it is reasonable to use blood products when available instead of crystalloids for ongoing volume resuscitation in child who has got hypotensive shock secondary to trauma when there is a hemorrhage or loss of blood is the reason. The reasoning is a growing body of evidence which is there suggests a benefit to early balanced resuscitation using packed RBCs, fresh frozen plasmas and platelets. Naloxone, we already talked about this. Although drugs is not a priority in our area, but if suppose there is a suspected opioid overdose, then naloxone may be used upfront, because an early dose of naloxone may be beneficial in patients who have taken drugs overdose. The reasoning is it can be given by trained providers, laypersons while focusing training, and untrained layperson. Separate treatment are provided for, algorithms are provided for managing opioid associated resuscitation by layperson who cannot reliably check for pulse and for trained rescuers. That is not very much applicable in our countries. And recommendation in myocarditis, the take home message over here is whenever this was true, especially during COVID, where we were suspecting that the child may have myocarditis, child may have congenital the heart blocks, where it is preferable that this child should be shifted to ICU as early as possible, because these are the patients who are likely to require defibrillator as early as possible. So here the patient should be shifted to ICU as fast as possible. Now this is important point, as we have been going all over the places for the CPR training for mass awareness. First of all, whether there is a willingness to perform bystander CPR. Now, to increase the bystander willingness to perform CPR, we need to have CPR training, mass CPR training, CPR initiatives, awareness initiative, and promotions of hand-only CPR, where there is hesitancy, which was already discussed in the after the first lecture, that people may be hesitant in using mouth-to-mouth respiration, but calls or compressions only CPR also should be given to them, because that is the only chance for the victim who was arrested. So prompt delivery of bystander CPR doubles the victim chances of survival from cardiac arrest. So again, we have already talked about these various activities through which we can increase the rate of bystander CPR. And summoning willing bystanders. Now there are few things which are new to this. Emergency dispatch system should alert willing bystanders to nearby events that may require CPR or AED. We can use mobile phone technology. Despite the recognition of role of lay rescuers, most communities experience low rates, which we already talked about. But with use of mobile phone technology, text messages, mobile phone apps, which are available, you can summon trained members of general public to nearby events to assist CPR. Now you can use maybe a video call. You can just show them how to use your CPR techniques. So because they have shown that it can improve bystander response time, it can have a higher bystander CPR rates. We already talked about this in the initial slide. Now there are cognitive aids and checklists. As the technology advances, we can have pocket cards, posters, checklists, mobile apps, mnemonics, which can just help a bystander CPR to be used. And for resuscitation education science, for lay persons, you can have self-directed training, either alone or with instructor-led training, to improve the willingness and perform the ability to perform CPR. Greater use of self-directed training may be removed an obstacle for more widespread training. Middle school and high school age children should be trained to provide high school CPR. This is the recommendation. And cognitive aid that I have shown that we can definitely improve the adherence to resuscitation guidelines, reduce the errors, and improve survivals. This is another thing. If you have generated enough data, then and if you create a registry of this cardiac arrest, then over a period of time, there will be definitely better outcome associated with real world management of cardiac arrest. So this is a need of the hour for tomorrow. So again, to conclude, take some time to learn first aid and CPR. It saves life and it works. So then the situation would not be like this, that the person who knew the CPR has laid down and nobody else knew CPR. With this, I conclude my talk. Thank you. If there are any questions, I'm happy to take them.
Thank you so much, Narendra sir, for highlighting regarding the guidelines in so much details. Thank you so much, sir. Now we are moving with the next session regarding the infant CPR. The session will be done by Dr. Meena Sheikh, sir. It's my honor to introduce sir. Actually, there is no words are required for him only. He is a mentor with me for various IIP modules. Sir had worked from PSC to CSC to Government Medical College, and at last now in the corporate hospital. He is the head of the Department of Pediatrics at Lilavati and most famous pediatric intensivist in Mumbai. Over to you, Meena sir.
Sachin, thanks a lot for little exaggerated my uh, initial preamble that you have said. I'm a very small person, but however, try to do the good work. So it's been pleasure to be around with my friends, Dr. Hemant sir, Dr. Amul, Mandar, Narendra, Sushma, even I see our EB, Dr. Ramakant sir. So lot has been talked about. I'll try to be on the topic that is given to me, that is infant CPR. And my like what I have decided, what we have decided, that we'll run the video first, and we'll have a small presentation from my end. So I kindly request Dr. Neha Singh to run the presentation, and then we'll have the slide from my end. So over to Neha, please. Yeah, let's start.
For the purpose of BLS sequence, the term infant means less than 1 year of age, excluding newly born babies in the delivery room.
In this clip, we will show you the CPR sequence for an infant, both by 1 and by 2 rescuers.
Coming through. The scene is safe. Baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4.
Since you have already seen the CPR sequence of an adult, it would be easy for you to understand the CPR sequence of an infant, which has many similarities. Assess for scene safety.
The scene is safe.
Assess the victim for a response.
She's unresponsive.
And if there is no response, shout loudly for a nearby help.
Somebody please activate the emergency response and get an AED.
Or send someone to get an AED or defibrillator and emergency equipment. Look for normal breathing and brachial pulse simultaneously to determine the next appropriate action. Breathing and pulse check should not take more than 10 seconds. In adults, the pulse is checked in the neck for carotid pulsation. However, because of short neck in infants, feeling for carotid pulse is difficult. Pulse check in infants is done by feeling for the brachial pulse by placing 2 or 3 fingers on the inside of the upper arm between the elbow and the shoulder. Press the index and middle finger on the inside of the upper arm to feel for the pulse. Remember, the whole procedure should take at least 5 and not more than 10 seconds. Next action will depend on victim's situation. If breathing is normal and pulse is present, monitor victim till emergency help arrives or the victim is taken to hospital. If no normal breathing but pulse is present, provide rescue breathing. If no normal breathing and no normal pulse within 10 seconds, begin high quality CPR with cycles of chest compressions and breaths in 30:2 ratio, starting with chest compressions using the CAB sequence. Use 15:2 ratio if 2 rescuers are present. Use AED as soon as it is available. If shockable rhythm, give 1 shock and resume CPR immediately for 2 minutes till prompted by the AED for next rhythm check. Continue cycles till ALS providers take over or the victim becomes responsive.
This video was self-explanatory with regard to assessment. Then there are 2 more videos. One is 1 rescuer infant CPR and second is 2 rescuer infant CPR. So let's see the 1 rescuer infant CPR.
Baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, two, three, four.
During the chest compression as a single rescuer to an infant, you will use just 2 fingers of one hand and use the other hand to tilt the head and keep the airway open. The infant should be lying on its back on a firm, flat surface so that the chest compressions will be more effective. Place the tips of 2 fingers in the center of the baby's chest, just below the nipple line. The pressure should be applied just below the imaginary line between the 2 nipples, avoiding the tip of the breastbone. Push hard and push fast to a depth of at least 1/3 of the depth of chest or approximately 1.5 inches. Maintain a compression rate of 100 to 120 per minute. After each compression, release the pressure on the breastbone, allowing the chest to recoil completely. Count out loud as you do sets of 30 compressions.
1, 2, 3, 4, 5, 6, 7.
This is called the 2-finger technique, and it is the perfect technique if you are the lone rescuer.
So this was one rescuer infant CPR. Then we'll go to 2 rescuers infant CPR. Yeah, please.
Coming through. The scene is safe. Baby, baby, she's unresponsive. Somebody please activate the emergency response and get an AED. She's not breathing. There is no pulse. Starting CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
1 and 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1 and 2.
1, 2, 3.
If no normal breathing and no normal pulse within 10 seconds, begin high quality CPR with cycles of chest compressions and breaths, starting with chest compressions using the CAB sequence. Remember, there are some important differences while performing 2 rescuer versus 1 rescuer CPR sequence in an infant. This includes a different hand placement and a different compression to breath ratio. Single rescuer chest compressions are performed with one hand, and the other hand is placed on the forehead of the baby to gently tilt the head back and keep the airway open. In 2 rescuers, since there is a designated person for the airway, the first rescuer can use both his hands for chest compressions using the 2-thumb technique. Do not press on the tip of the breastbone.
1, 2, 3, 4, 5, 6, 10, 11, 12, 13, 14, 15.
1 and 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1 and 2.
1.
Use 15:2 ratio. Use AED or defibrillator as soon as it is available. If shockable rhythm, give 1 shock and resume CPR immediately for 2 minutes till prompted by the AED for next rhythm check. In an infant, because of the small size of chest, the thumbs may overlap during compressions. In case of an infant, the rescuer can switch roles after every 10 cycles of CPR to prevent fatigue. Continue cycles till ALS providers take over or the victim becomes responsive.
Thank you, Dr. Neha. Then I'll try to share my screen. Okay. So, is it visible? Right. So what
Yes.
so far we have learned is about there was a good presentation by Dr. Sonali. Practically, she has covered everything. Then a good science about Dr. Nani. And then I'm talking about small thing about pediatric cardiac arrest. To review and revise, the pediatric cardiac arrest are of two types. One is hypoxic or asphyxial, which is most common. And second is sudden cardiac arrest. The sudden cardiac arrest are of two types because of two reasons. Either it is ventricular fibrillation or ventricular tachycardia, or we can have bradycardia with poor perfusions. So what is important is that not breathing and pulse rate, not breathing with pulse rate have a better outcome. And pediatric out of hospital cardiac arrest, survival to hospital discharge up to 11%. Important figure. So out of hospital cardiac arrest, pediatric survival to hospital discharge is 11%, wherein pediatric intra-hospital cardiac arrest, survival to hospital discharge is up to 49%. Very important. And for BLS point of view, how we have categorized, there are four categories: neonate, infant, child, and adult. We don't treat neonates. Neonates up to 30 days. Infant is 1 month to 1 year. Child is 1 year to up to start of puberty. And adult is puberty and older. And what's important is the sequence, the CAB, CAB. Earlier it was ABC, but AHA and LCOR has promoted CAB. CAB is chest compression, airway, and breathing. And before we really go into this, what I am trying to let you know, we should understand what is shockable rhythm. The shockable rhythm are only two. That's ventricular fibrillation and ventricular tachycardia. So to summarize, these are the components of BLS: adults and adolescents, children, and infant. So scene safety is common in all. Make sure the environment is safe for rescuer and victim. Recognition of the cardiac arrest is almost identical. We have to check for responsiveness. What is important is no breathing or only gasping, or in world word, no normal breathing. So let's have no normal breathing as no breathing or gasping, and no definite pulse felt within 10 seconds. So don't let the time go beyond 10 seconds with regard to pulse identity. And both the things can be performed simultaneously. The next step is activation of emergency response system. That's been there. There are two types of collapse: witness collapse and unwitnessed collapse. Witness collapse, we have to follow the steps of adults. That is, if you are alone with no mobile phone, leave the victim to activate the emergency response system and get the AED before beginning CPR. Okay, fine. So next is compression death, very important. So compression death in, sorry, I'm going back. So compression depth in adult is around 2 inches, wherein pediatric it is around, adult is 5 to 6 centimeter, pediatric is around 5 centimeter, and infant is around 4 centimeters. So at least 1/3 of the AP diameter of the chest. This is very important. Next is hand placement. That has been told in adult as in pediatric. The difference in adult and pediatric is that pediatric two rescuer, we can have 2 hands and 1 hand encircling the chest complete, and one rescuer will have 2 fingers. What's important is to have the chest recoil. The chest recoil is very important because not only it should go down, it should go up, because when it is up, then there is a cardiac output. So essentially the chest recoil should be appropriate. An important component is minimizing interruption less than 10 seconds. Then the compression ventilation ratio, as I already been told, by default, whether it is 1 rescuer or 2 rescuer in adult is 30:2. But in pediatric, 1 rescuer is 30:2 and 2 or more is 15:2. This is important. And compression ventilation ratio in both are identical. Almost in all age it is identical. That's not less than 100. They have studied if the compression ventilation ratio is less than 100, then the outcome is not favorable. So essential component is your sensitivity, recognition of the cardiac arrest, activation, compression depth, hand placement, chest recoil, minimizing interruptions, compression ventilation ratio, and compression ventilation with the advanced airways in place. So this is in brief, and that's all from my end. Thank you. Stop sharing. Do I do? Or that's all. Neha, stop sharing, right? Okay. Any question?
No, sir. Right now there are no questions. Thank you, Minas sir, for excellent deliberation. Now I request Mandar sir, is a pediatric intensivist from Aurangabad, well known. We all know him very well. Sir is a national ALS based zone coordinator for 2021, PALS instructor since almost 15 years, and director of Amrut Children's Hospital, almost 60-bedded hospital in Aurangabad, which is very famous for pediatric procedures and intensive care. Now over to you, Mandar sir.
Thank you, Dr. Sachin. And at the outset, I would like to thank Maharashtra IIP President Dr. Hemant sir, Secretary Dr. Amol for raising this important issue on Maha IIP platform. I also like to thank Dr. Minas sir, Dr. Nani Wadikar and Dr. Sonali for giving me an opportunity to be with you as a co-faculty and share some views on the most easiest of all the CPR topics, but very reluctantly managed when it comes to real choking. Now we'll discuss about choking. I'd like to share my screen first and then I will show the videos. Okay, before we start looking at this PPT, there is very important thing one should keep in mind and know is that what is choking and what is coughing. If the child is able to cough properly, or if the child is able to take out the Dr. Neha, can you help me please? I'm not able to share the screen.
Sir, do you want me to share?
No, screen is shared, but you just go to the videos. You are not able to go to the videos. You have shared your screen. We are seeing your screen. Just go to the folder, video folder. Go to the video folder. Where is your video folder? No. This you minimize. This is your Zoom one. This you minimize. You will not find it. Minimize Zoom. Now you just go your folders.
Right.
Are your videos on the PPT? In the PPT?
No.
Yes.
Yes.
Is the screen visible now? The slides visible?
Yes.
Okay. So there is a basic difference between coughing and choking. What is coughing? Coughing, if the child or if the adult is able to cough out and is coughing forcefully, best thing is to do nothing. Ask him to cough out the foreign body. So anyone who comes with a history of foreign body in the airway, maybe a piece of food, maybe a piece of non-veg, maybe any piece of vegetable, and if you see that if the adult or if the child for that matter is able to cough it out and the coughing is clearly audible, don't do anything. Just ask him, are you choking? If the victim says he's choking or is not able to speak it out, then you have to attempt for getting the relief of the choking. Do not give anything to drink until the choking is clear. And coughing, if not able to bring up the object, then only you have to intervene. If the cough continues for a longer time and you find that there is something in the throat, just take this child to this victim to the emergency room or the nearby hospital and help. Otherwise, don't try to intervene anyone who is coughing loudly with a foreign body inside. Okay, let him try and get the cough out the foreign body. If he feels that he becomes unresponsive, or if he's showing signs of choking, then only you have to intervene, otherwise not. So what do you mean by choking? A victim cannot speak, victim cannot cough, victim cannot cry, or victim cannot breathe, victim is turning blue or holding their neck. In that case, it is choking. Here the airway is blocked. This is an emergency. You will have to call the ERS, and this is a sign which is shown in the slide. This is called as a universal choking sign. So what are the signs of choking? Already discussed. Clutching of the throat. If the person doesn't give the signal, look for the indications like inability to talk, difficulty in breathing, noisy breathing, inability to cough forcefully, the skin, lips are turning blue, and the child is, or the victim is becoming unconscious. So what will you do? For a victim who is an adult, in a BLS, anyone who is above puberty is adult, and anyone who shows signs of puberty and above that is adult, and from 1 to 8 years is a child. So for relief of choking, adult and pediatric choking, both will have to be managed in a similar way. And the maneuver which we do to get a relief of this choking is called as a Heimlich's maneuver. So what is Heimlich's maneuver? We'll demonstrate that through the video, but just taking at this, going through the slide, you have to stand behind the victim, wrap your arms around the waist, tip the person a little forward, slightly forward, make a fist of one hand, put it just above the level of navel, and grasp the fist of the other hand and push hard as if you are trying to take out the foreign body, as if you are trying to make a cough reflex. So you have to perform this abdominal thrust, if needed, 5 thrusts at one go, and these thrusts need to be distinct, like one thrust, wait for some time, do another thrust, so that at every thrust you can see that the foreign body is coming out or not. If the foreign body still isn't dislodged, you may repeat 5 and 5 cycles again. So this is a video, this is an audio, this is a slide which suggests us that how abdominal thrust is taking out and how the foreign body can come out actually. So while doing this, if the victim becomes unconscious, unresponsive, you are doing a abdominal thrust and the victim becomes unresponsive, what will you do? You will make him lay down on a firm flat surface. You will start chest compressions and follow standard CPR guidelines as Dr. Sonali mentioned. With each time you open the airway, you should look for the foreign body and take it out. Don't perform blind sweeps. And if the emergency response is there, the system is there and it takes the care of the patient, the victim, let the patient be shifted in the emergency response system. If you are able to successfully take out the choking of a particular child or victim, then what are you going to do for recovery? Check to make sure victim is breathing normally. Encourage the victim to sit down and reassure. And here very important is that check victim for any pain, any swollen abdomen or painful ribs. Because invariably when you are doing abdominal thrust, there is a chance of injury to ribs or the abdominal organs. Go to the emergency room with any of these abnormal findings. This was about Heimlich's maneuver and adult choking and the pediatric choking for that matter. But when it comes to infant, the scenario changes, the maneuver changes. You are not going to give abdominal thrust to infants. So what are you going to do? So you are going to do back slaps and chest thrusts. So what do you mean by back slaps? An infant should be held with one hand with the body resting across the forearm and the thumb, index finger, so that the as shown in the picture, the victim should be the neck and the head end of the victim should be little on the lower side as compared to the legs. And you have to give back slaps. And where have to give the back slaps? In between the scapula with the heel of your hand. So you have to slap it like this, distinct force. Each slap should be distinct and it should be with a force to try out the foreign body come out. So if you are able to do it with 5 back slaps, nothing like it. If you are not able to do that, then turn the victim around as a torso. You have to turn the victim as a unit and do 2-finger chest compressions. Now, if you continue doing it 5 back slaps and 5 chest thrusts until the baby begins to cough, is able to take the foreign body out, or the infant becomes unresponsive, that is unconsciousness. So if the infant becomes unconscious, what will you do? The baby becomes unconscious, the steps of the CPR should be followed, and every time you open the airway, you should look for the foreign body. And the most important thing here will be don't perform blind sweeps. Means you are not able to see the foreign body in the oral cavity, don't perform blind sweeps. Because if you're trying to take out the blind sweeps, it will be more traumatic, it will lead to more asphyxia, it will lead to more complications. So don't ever perform blind sweeps. Okay, this was regarding infant choking. Now we'll go through the videos and then we'll see if you have any questions. Dr. Neha, please run the video of adult choking.
You have to stop sharing.
This is infant choking. Okay, we'll go with the infant choking first, not an issue. Go ahead.
We have seen choking in adult and older child. Now we shall see choking in an infant, although the basic principle remains the same. The steps to relieve an infant from choking differs from an adult. If you find an infant with severe choking, you should sit or kneel with the infant on your lap. Hold the infant's face down with the head slightly lower than the chest, resting on your forearm. Support the head and jaw with your hands. Remember that while doing so, you should avoid compressing the soft tissue of the infant's throat. Rest your forearm on your thigh to provide support. Deliver up to 5 back slaps between the infant's shoulder blades using the heel of your hand. Deliver each slap with sufficient force so as to remove the foreign body. Then place your free hands on the infant's back, supporting the head with the palm of your hand. This will prevent the infant from falling off and also act as a support for the head and the neck. Keep the infant's head lower than the chest and deliver up to 5 quick downward chest thrusts just below the nipple line over the lower half of the breastbone. This should be done at a rate of 1 per second. Repeat the sequence of 5 back slaps and 5 chest thrusts until the object is removed or if the infant is found unresponsive. When your maneuver is unsuccessful or if the victim becomes unresponsive, then shout for help. Lay the infant on a hard, flat surface and start CPR. When you give chest compressions, an object may come out of the throat or you may be able to see the object. So, remember that each time you open the airway to give breaths, you should look for the obstructing objects at the back of the throat. If you can see the object, then perform a finger sweep to remove it. You should never perform a blind finger sweep. If you are alone and there is no improvement even after giving 5 cycles or performing 2 minutes of CPR, then activate the emergency response system.
Thank you, Dr. Neha. Can we have a video on adult choking? So the video which we saw earlier was like infant choking. Now we are going to see the adult choking.
Hey, look, he's choking. Are you choking? Are you okay now? Just sit down. Better?
When food or other item blocks the person's airway, choking occurs. You may see the universal choking sign where a child or an adult may clutch their throat with both hands. In scenarios where there is severe airway obstructions, the victims will have signs of poor air exchange and breathing difficulty, such as silent cough, cyanosis or turning blue, and inability to speak or breathe. If you find any of these signs, you should immediately ask if the victim is choking.
Are you choking?
If the victim is not able to talk and nods his head, then you must act immediately. In standing or kneeling victim, you will perform abdominal thrust, also known as the Heimlich's maneuver. Stand or kneel behind the victim and place your arms around the victim's waist. With one hand, locate the navel. Then make a fist with the other hand and place the thumb side of the fist against the victim's abdomen, just above the navel and below the breastbone. Grasp your fist with your other hand and press your fist against the victim's abdomen with quick and upward thrust. Repeat the thrust until the object is expelled from the airway or the victim becomes unresponsive. If the victim is too large to wrap your arms around the waist or is pregnant or overweight, then wrap your arms around the chest and do chest thrust instead of abdominal thrust. Even after doing the Heimlich's maneuver, if the victim shows no improvement or becomes unresponsive, then send someone to activate the emergency response system. Perform CPR using CAB sequence, but be sure each time you open the airway to give breath, look for the obstructing object at the back of the throat.
Yes, this was regarding infant and adult choking. Thank you. Over to
Thank
you,
you so,
Dr.
thank you so much, Mandara sir, for nice video and nice technique. All the very well explained by sir. Now, Ramakant Patil sir is there in the audience. Sir, please have few words regarding sir. Ramakant sir, I think he is not there. Okay.
Dr. Renu
Uh,
is there. Renu.
Yeah, I'm here.
Yeah. Okay.
I had muted, but it takes time to unmute it. Yeah. So wonderful
Welcome, sir,
presentation.
on behalf of MIP. Welcome.
It was very nice and wonderful. The whatever pulse course of 2 days has been covered in 1 day, and nearly everything is covered. And wonderful presentation on this CPR week, not only CPR day. I congratulate all under able guidance of Nani Udekar and you all people and Dr. Mina Sheikh sir and wonderful activity by Maha AP. You are just rocking. Congratulations.
Thank you, sir. Renu madam is there?
Yes,
Yes,
yeah.
ma'am.
Congratulations to you all and our Maha-IP who have conducted this CPR course. And I heard all the things and congrats to Dr. Sonali, Dr. Nani sir, also Dr. Meena sir and our own Mandar Deshpande from Aurangabad. And it was a very good video presentation which was very much appreciable, and to all our local pediatricians we should also I think so share the videos if permitted. Yeah, and congratulations to you too, Dr. Patil.
Thank you, ma'am.
Yeah.
Many thanks to MahaIP for giving me this opportunity for moderating this session. Now I request Amol sir, our Honorable Secretary, please give us some closing remarks.
Any
Amol
questions
sir?
from audience? Any questions from
Questions, I
audience?
think.
It was
No, sir.
very crisp. It was very crisp, so we have understood everything. So
More
no
of
question.
practical.
Yeah.
Video
No,
based.
all these things are so well formulated and nothing to be told out of that. Whosoever to have a uniformity. So there won't be any question on this. If at all there will be
Right.
question, it will have to be very studied one and from AHA. Like, so it is a wonderful prepared this thing and constantly updated guidelines from ALS. So
Yeah.
there are less likely to be any, there will be doubts, but no questions.
Thank you, sir.
Yes, sir.
Amol
Yes,
sir, please.
Thank you. Thank you, Dr. Sachin Patil from Yavatmal for carrying out this wonderful session on CPR Day and week as a part of IAP activity. I thank Dr. Mandar Deshpande sir, Dr. Meena Sheikh sir, convener of IAP ALS BLS, Dr. Narendra Nanivadekar sir, and Dr. Sonali Shirbate ma'am for their time given for this session. I also thank Dr. Hemant Gangulia sir, then Dr. Neha Singh for helping out for this activity. Then with this, I also have, take opportunity to thank all the faculties of IAP, ALS, BLS across Maharashtra, and also all branch OBs of IAP branches who are working very hard in spite of their busy monsoon OPDs for the success of this IAP CPR Day and week activity. Many branches have carried out this activity in various hospitals for RMOs and healthcare givers. Some branches have carried out this activity in general public also, auto rickshaw drivers, bus drivers, at bus stations, they have carried out this activity. With this, I again thank all these stalwart faculties for helping us out in carrying this wonderful CPR Day activity. Thank you, one and all.
Thank you, Amol sir. Now you can conclude this session. Thank you so much.
Thank you, sir.
Thank you all.
Thank you.
Thank you, everyone.
Thank you very much.
Thank you, Nani sir. Thank you.
Special
thank you.
Neha
Thank
for
you.